So I'm now going to talk a little bit about chemotherapy and its role in bladder cancer. So bladder cancer, as you've been hearing today, is a relatively common cancer. The majority of patients, 75%, have superficial local disease. Another 20 to 25% have muscle-invasive disease, which we were just hearing about cystectomies for muscle-invasive disease. What wasn't mentioned is that patients who have muscle-invasive disease who undergo cystectomy, of all comers, 50% of them can go on to recur and get metastatic disease. Only about 5% or so of patients, when they're diagnosed, already have spread of their cancer. So usually it's not spread at first, but those people who go for curative therapies with local therapies still have a significant risk that their cancer may come back. So chemotherapy is something that we use to treat bladder cancer either in combination with local therapies, or for patients with distant disease, we use it as a solo therapy. And what is chemotherapy? So the word chemotherapy, I know earlier you were hearing about things that we call targeted therapies. Chemotherapy, very simply, are chemicals that are used to kill cancers. And this little picture down here represents a dividing cancer cell. And when cancer cells divide, they're most susceptible to being killed. So that's what chemotherapy is intended to do. And when you're talking about bladder cancer, and you're talking about localized bladder cancer, one that someone would be having treated with either surgery or radiation, you might be talking about getting chemotherapy either in a neoadjuvant therapy. That means before you have your surgery or radiation. You might be getting it in an adjuvant setting, which means after you've had your local therapy, so you get your bladder removed and then you get chemotherapy. Or you might be getting it at the same time that you're getting a local therapy. Now, that wouldn't be the surgery, but if you were getting radiation, if someone was trying to do a bladder-preserving radiation, you might get chemotherapy at the same time that you're getting your radiation. So the reason that one might want to give chemotherapy is, first of all, as I mentioned in that early slide, bladder cancer, even when it's localized, has a high chance that it can spread or metastasize. It is chemosensitive, meaning there are chemotherapy drugs that can kill bladder cancer cells. However, when bladder cancer spreads, chemotherapy is not curative. So you want to try to enhance the benefit of killing cancer cells when maybe there's just a small volume of disease. So either after you've removed the bladder with the idea that there are a few cells left behind, and you have to realize that if your cancer comes back, it's because a few cells were left behind, whether they know that or not at the time of surgery or radiation. So those few cells are a small volume, and they might be more sensitive to chemotherapy, hence the idea that you could add chemotherapy before or after whatever you're doing for localized disease and improve the chance that your disease stays away. So far, we have a few studies that support the value of chemotherapy in addition to surgery or radiation. So this is a trial. This is a European group, big research group that took men and women who had localized bladder cancer, so T2, 3, or 4, which are all still localized. So these were all people that were felt to be candidates for localized therapy to cure their cancer. And before they had that local therapy, they got what's called a cycle, 3 cycles of chemotherapy with a combination of a drug called cisplatin, one called methotrexate, and one called vinblastine. So those are 3 common chemotherapy drugs. And the most active chemotherapy drug in bladder cancer is cisplatin. So they got 3 cycles, which means several treatments with chemotherapy over a few months, and then they went on to have their local therapy. That could be either surgery or radiation. So when they first reported this study, you see that these curves, this is survival. You can see these curves spread a little bit. The top line is the survival of the group that got chemotherapy before their local therapy, and the bottom line is those who did not. So there was a tiny little difference at 3 years. It was a 5.5% survival difference favoring the chemotherapy. One of the other things they found is that when they got to the time of surgery, and they took out the bladder, about a third of the patients actually had no evidence of their cancer when the bladder was removed. I should tell you, just because of that in a subsequent study I'm going to mention, patients who find that they are free of cancer after chemotherapy, if you don't go on to remove the bladder or radiate the bladder, their bladder cancer is going to come back. So chemotherapy, be it neoadjuvant or adjuvant, by itself is not a curative therapy. But at least to the pathologist's eye, there's no cancer left behind in about a third of the patients. So there was this 5.5% survival benefit at 3 years. They then went and followed these patients another several years, and at 7 years, there was about a 15% decrease in the risk of dying if you got the chemotherapy before you got your local therapy. So in the United States, a second trial was done, and it was done with a regimen known as MVAC. So MVAC was developed at Memorial Sloan Kettering, and it was it was considered sort of our best chemotherapy for years, and I'll mention a second combination that it's been compared to. But MVAC is 4 drugs. Again, we've got the methotrexate, the vinblastine, and the cisplatin that we saw in the other regimen, but now we've also got adriamycin. And this is given as a cycle. So a cycle is every 28 days. And you don't get it every day. You get it like the first day, the 15th day, and the 22nd day of each cycle. And you would do that 3 times. So in the United States, they did a trial, a neoadjuvant chemotherapy. In other words, before these patients were going to go to surgery. So again, it's stage T2 to T4 disease, so a localized cancer. It's not in the lymph nodes. It's not metastatic. These are people that you thought you could cure by removing their bladder with a cystectomy. And half the patients got 3 cycles of this chemotherapy, the MVAC chemotherapy, in the neoadjuvant setting before their cystectomy, and the other half did not. And then they followed these people, and then at a median follow-up of about almost 9 years, the survival difference was 6.4 years versus 3.8 years for the patients, favoring the patients who got the chemotherapy. Now, if anybody knows much about statistics, you have to meet something called, the p-value has to be 0.05 or less, so it was just right there at the edge. And these are survival curves. The people up here, these are the ones who have the real good advantage. These people are people who, when you get to surgery, you don't find any cancer left in their bladder. And these are people who either did not get chemotherapy or they did have residual disease left in their bladder. So the big advantage of giving chemo before, the people who really get the benefit are those who, when they get to surgery, there's no cancer left in their bladder. So this is sort of another slide showing surgery with chemo before versus no chemo before. That's the study I just mentioned. And then this is what's called the meta-analysis. They took all of the studies they had where patients either, including the European trial and a third trial, where patients got chemo before they went to surgery or did not get chemo. And you can see that these curves are not hugely different, but a little different, favoring chemotherapy. So the meta-analysis involved about 2,700 patients, and they showed that people who got chemotherapy that contained cisplatin before they went to surgery had a benefit in terms of overall survival, a 13% decreased risk of dying, and there was this 5% absolute benefit at 5 years. So there's this trend towards better survival, and the current guidelines tell us that if you have muscle-invasive bladder cancer and you're planning to go to surgery or even radiation, that you should see a medical oncologist who should discuss whether it might be beneficial if you got chemotherapy beforehand. Now, the regimen that we usually use now, rather than MVAC, is a regimen called gemcitabine and cisplatin. So it's only 2 drugs. Again, it's a 28-day cycle. Again, a neoadjuvant chemo is 3 cycles, and gemcitabine and cisplatin is preferred over MVAC because it has less side effects. So one of the questions is, okay, so some patients will say, maybe they either didn't see a medical oncologist before surgery, or they said, well, what if my cancer looks really good at the time of surgery? It hadn't gone through the wall of my bladder. It's not in my lymph nodes. It's, it was sort of very well confined. Maybe I don't need the chemotherapy. Why don't I wait and let's just see what the surgery shows? Besides, I'm a little nervous about doing chemotherapy, and how about if I take it after surgery? So adjuvant chemotherapy is chemotherapy given after your local procedure, and the question is it equal to neoadjuvant? Well, these are a whole bunch of clinical trials that have been done trying to show whether adjuvant chemotherapy is beneficial. And this is the survival benefit, yes, no. And we have a couple here. This one is a Spanish trial that was recently reported. And what the problem is and why no one's been able to be as strong about favoring adjuvant chemotherapy as neoadjuvant is that most of the studies are stopped before they're finished. They're either small, they weren't designed well, and so we have not been able to clearly answer the question about whether adjuvant therapy really improves your outcome the same way as strongly as we feel about neoadjuvant. So this was the trial that was reported at our big oncology meeting, we call that ASCO, in 2010. This was a Spanish trial, and these are patients who had their bladder removed, and they were considered to be at risk for recurrent disease. Either it was through their bladder wall or it was into the lymph nodes, and they got 3 chemotherapy drugs. Now we've added in a drug called paclitaxel or Taxol to the gemcitabine and the cisplatin, or they didn't get that. But the problem is that this study was only 142 patients went on this study before it had to be closed, and so as a consequence, the benefits may or may not be true when you have a study that's smaller than anticipated. Why these studies close, and this is a group, an advocacy group and a network, is because people don't want to go on clinical trials, which is something that, if we want to make improvements, we need to, people have to go on clinical trials for us to make advancements in treatments of bladder cancer. So this trial did, though, look sort of positive in the sense that when they followed these patients and they looked at how many people, for example, so they followed them for several years, and if you looked at how many people had died from their cancer or died, you see that 24% of the patients who got the adjuvant chemotherapy had died, and 61% of those who had not. So certainly that looks like a difference. If you look at time to progression of their cancer, 44% of the patients who got the chemotherapy had progressed compared to 73% who had not gotten the adjuvant chemo. So it looks very positive in that sense, but one, the study was never completed, and two, patients often went on to get further chemotherapy. So although this is the group that were the adjuvant group, about a half of those patients went on to get chemotherapy. Those who were in the observation group, about 70% went on to get chemotherapy, and more of the patients in the observation group got platinum-based chemotherapy. And so it sort of became a chemo now, chemo later story. And so the patients so it's not a true study to analyze how the reason that the groups were different. So the EORTC, which is is the biggest European oncology group that does clinical trials, they also tried to do a study, an adjuvant study, and they took patients who had their bladder out for localized disease, and they either gave them chemotherapy now, and you could choose what you gave them. You can give them the gemcitabine cisplatin, you can give them the MVAC, you can give them a high dose of MVAC, or you can wait until their cancer comes back. But again, that trial did not complete. It was closed early. So we have problems in the setting of adjuvant. We don't have sufficient evidence to say you should definitely do it. You would have a conversation with patients, and if you believe that they were at significant high risk of their cancer recurring, such as it was in their lymph nodes, you could talk about the idea that you would get adjuvant chemotherapy, but no one could say, we can absolutely tell you must do this if you want to improve your outcome. So we do feel that patients need to know about neoadjuvant chemotherapy. There is enough data to support its benefit. And if a patient does not want neoadjuvant and they've had surgery, they should have a discussion about adjuvant chemotherapy, but the data is a little less compelling. Radiation I mentioned there is radiation can be done as bladder sparing therapy. Everyone, although the gold standard is to remove your bladder, some people, because of illness or just choice, do not want to have their bladder removed. And so this is a series of studies showing what's the chance you can get a complete response with radiation. And you can see that up to, one study was as high as, but up to about 50% of patients can actually get a complete response to radiation. And if you add chemotherapy, so this is the C is cisplatin or carboplatin. So if you add a platinum, the chances of getting a complete response goes up more in the order of 70%. And if you add chemotherapy, so if you choose to get bladder sparing radiation, you should get it in combination with chemotherapy, which most people give as like a weekly chemotherapy dose, most commonly cisplatin or cisplatinum and 5-FU. So this is a bladder sparing sort of approach. So the patient who has a cancer that's confined to their bladder undergoes what's called the TURBT, transurethral resection of the bladder tumor. Then they start radiation, and they get cisplatinum and 5-FU at the same time they're being radiated. And after the first several weeks, about 5 weeks of radiation, someone goes and looks in their bladder. And if you look in the bladder and everything is gone and you don't see any cancer, you can continue with the radiation, and then you follow it with adjuvant chemotherapy. If, on the other hand, there's residual cancer left in your bladder, you would proceed to have your bladder removed. And that's a common approach if you want to do a bladder conservation approach. Now, metastatic bladder cancer is unfortunately does occur in up to half of the patients who end up having their bladder treated locally, as well as in about 5% or so of people at the time they're diagnosed. And bladder cancer, when it does spread, most commonly it's going to go to regional lymph nodes. It can go to lung. It can go to other places. It can go to liver, skin. It can go to brain. It can go to bone. But most common are lung and lymph nodes. So the chemotherapies that we use for metastatic disease are either MVAC or most recently we mostly use gemcitabine cisplatin. So cisplatin, I said, is the most active chemotherapy we have for metastatic bladder cancer when compared to a combination regimen like MVAC. If you look at how long people live when they have bladder cancer, and this is really sort of the why we need to do more research, the median survival with combination chemotherapy in people with metastatic bladder cancer is just about a year compared to, but it's superior to use more drugs than just a single dose of cisplatin, which if you just did that, it'd be about median survival of 8 months. So the combination MVAC was better than another combination known as Cisco, which is fewer drugs. It's got Cytoxan, adriamycin in it. And the other regimen that we use is the gemcitabine cisplatin. Now, the reason gemcitabine is the most, cisplatin is more popular is because of less toxicity than MVAC. So we know that there's lots of different chemotherapy drugs that actually have activity in bladder cancer. We've mentioned methotrexate, that's adriamycin, vinblastine, ifosfamide. These are all single agents that have activity. I don't know what, this unfortunately is on an automatic. Sorry about that. But and we know that MVAC, the combination, is better than just cisplatin alone in improving overall survival. And there's actually a little tiny group of patients that actually may be cured with chemotherapy for metastatic disease. But MVAC does have significant toxicity, and so a clinical trial was done comparing the MVAC regimen with just gemcitabine and cisplatin. And in both cases, when people have metastatic disease, we usually give 6 cycles of chemotherapy, partly because that's about how much people can tolerate, and then they stop treatment and wait until their disease progresses again. So they get a time off, so their disease may be completely gone or it may be partially gone. So in this study, both groups got 6 cycles of chemotherapy, and then if you want to know how well it works, so as far as response rate, the response rate to chemotherapy is about 50%. and that includes about 12% of patients who it completely goes away, and about 35% of patients in which it partially or 50% or more goes away. But the survival for chemotherapy in the metastatic setting is in the order of about 14 months, and gemcitabine cisplatin is equal to MVAC as far as side effects. What it was better as and why it has taken over as the standard was toxicity. So this is patients whose white blood counts go down and they get a fever. These people, white blood count goes down and they get really sick, something called sepsis. I don't know how to, sorry, I can't control that. This is mouth sores, mucositis, and this is dying from complications of chemotherapy. And so if you look at MVAC compared to gemcitabine cisplatin, getting an infection or getting mouth problems or dying of chemotherapy is higher, and therefore gemcitabine cisplatin is used commonly. So what do we use after first-line chemotherapy? Well, we don't have a standard what to do next. If you have someone or yourself, if your cancer has progressed through a combination chemotherapy, it would be best if you actually went on a clinical trial looking at some of the drugs that we're trying to develop. They may be targeted drugs, they may be chemotherapy drugs. There are several. These are all trials of single drugs and the activity rate of how well they work. The ones that are most commonly used second line are pemetrexed or paclitaxel or docetaxel are probably the three most used as a single agent. And if you look at how well they work as far as response rate, it's all in the order of 10 to 25% response rates to second line chemotherapy. And as far as expected survival after you start chemotherapy, it's in the order of 6 to 8 months on the clinical trials. So after cisplatin-based first-line chemotherapy, we don't have anything established to do next. We usually will give single agents, but these are patients who are strongly encouraged. All patients are strongly encouraged to get involved in clinical trials, but especially patients who have failed initial chemotherapy. Or progress through, rather. So bladder cancer is a common cancer, as we all know. It also can be a deadly cancer. If you're making decisions about what to do, neoadjuvant chemotherapy does have a survival benefit for muscle-invasive disease. Adjuvant chemotherapy really is not as established. We still need to it would be nice if we could finish a clinical trial. Gemcitabine cisplatin is the alternative, less toxic therapy for metastatic bladder cancer, and obviously we need new treatments. That's my last slide.